Good morning, everyone, and welcome to today's webinar on genetics and fertility featuring Dr. Kristen Wright from Boston IVF's New Hampshire Center. Before we get started, I would like to go over a few quick items about today's event. First, all physicians in attendance will receive an AMA PRA Category 1 credit, and all other providers will receive a certificate of completion for 1 contact hour credit. Additionally, we encourage you to submit questions to Dr. Kristen Wright using the questions section of the control panel. You may send in your questions at any time during the presentation. We will collect these and address them during the question and answer session at the end of today's presentation. Now, I would like to introduce you to today's speaker. Dr. Kristen Wright is a board-certified reproductive endocrinologist at Boston IVF and an assistant professor at Dartmouth College's School of Medicine. Dr. Wright completed her reproductive endocrinology and infertility fellowship training at the University of Vermont College of Medicine and her residency in obstetrics and gynecology at Brown University Medical School. For 8 consecutive years, New Hampshire Magazine has recognized Dr. Wright as the top New Hampshire fertility doctor. Dr. Wright is the lead physician at our New Hampshire fertility centers and now practices at our brand new Bedford, New Hampshire location with the first IVF lab in New Hampshire. She specializes in all aspects of fertility care. Now I'm going to pass it over to Dr. Wright.
Thank you for that nice introduction, Alyssa. This is my first time doing an online lecture, so hopefully this will all go smoothly and we won't have any technical difficulties. So our topic today, I thought it would be useful and timely to go over preconception genetic screening. The landscape with respect to genetic screening is rapidly changing, and I think will continue to change. So I thought it'd be useful to go through that with you today. I do not have any disclosures. Our objectives today are to understand the evolution and current role of genetic carrier screening, both prior to pregnancy as well as during pregnancy, and also understanding the ways in which we can test embryos at the time of IVF. We're going to go over different types of preimplantation genetic testing, including PGT-A, PGT-M, and PGT-SR, to get you familiar if you're not already with some of those acronyms. And along the way, we will talk about an evidence-based approach to applying these treatments in care. So let's start with the definition of genetic carrier screening. Genetic carrier screening is performed on an individual who does not have an overt phenotype for the genetic disorder, but carries a gene associated with a disease diagnosis. You are all familiar with Punnett squares, so a majority of diseases that we would screen for preconception are either autosomal recessive, which is portrayed on the left, or X-linked recessive diseases. So in autosomal recessive diseases, each parent is a carrier of the disease. Those individuals will have a 25% chance of having an unaffected child, a 25% chance of having an affected child, and a 50% chance of having a child who's a carrier as they are. With X-linked recessive diseases, daughters are typically unaffected, but sons have an approximate 50-50 chance of inheriting the genetic disease. So who should we screen? This is taken from the ACOG committee opinion about genetic carrier screening. States that genetic carrier screening should be offered to all pregnant women. This allows women to consider prenatal diagnosis as well as pregnancy management options. However, they also note that carrier screening should ideally be done prior to pregnancy. That does allow couples to pursue a broader range of reproductive options, such as whether to become pregnant, whether to use donor gametes, or whether to use advanced reproductive technologies. Genetic counseling regarding genetic carrier screening is incredibly important. If an individual is found to be a carrier for a recessive disease, then the reproductive partner should be offered screening. Typically in the REI world, patients and partners are screened concurrently, so both of them are screened at the same time. This is nice, especially when time is of essence, since most infertility patients want to get started on treatment. In the OB world, typically because you are seeing the mom and not necessarily seeing the dad or the sperm donor, the testing is often done sequentially. So the mother would be screened first, and then if a positive screen is identified, then the partner can be brought in for screening. Genetic counseling is, as I said, extremely important, especially if both partners are found to be carriers. Even if only one partner is found to be a carrier, it is helpful to counsel them about what that means and implications for their family. Finally, it's important to note that prenatal screening does not replace newborn screening. So, as I mentioned, an important component of genetic counseling is for the patient or couple to be educated that other family members may be affected by that same mutation. Patients should be encouraged to inform their relatives of the risk and the availability of carrier screening for their relatives. However, patient confidentiality is obviously very important, as you all know, so you cannot disclose genetic test results to a family member without the express consent of your patient. Okay, so that all sounds pretty straightforward. So which diseases should we be screening people for? Well, this is where it gets a little bit more complicated. So I thought it would be useful to go through the evolution of how genetic carrier screening has evolved over time. You know, you feel like you're getting old. I shouldn't say I'm old, but perhaps in the middle of my career, when you look back and realize how much medicine has changed since when you were in training. So back in my day, the only disease that we really regularly screened for was cystic fibrosis. This was recommended and introduced into routine obstetric practice in 2001 with a recommendation from ACOG. The incidence of cystic fibrosis is highest in white non-Hispanic individuals who have a carrier frequency of 1 in 25. The carrier frequency is considerably less in other ethnic groups. For a while, it was debated who should be screened, whether we should just be screening white non-Hispanics or whether we should be screening everybody. And in 2005, ACOG recommended that this be a pan-ethnic recommendation, so all patients should be offered screening for cystic fibrosis. As you all probably know, cystic fibrosis is a multi-organ system disease that predominantly affects the lungs and the pancreas. In its severe forms, it can result in a significantly shortened lifespan. This is a very well-described gene at this point, and there are both severe as well as mild mutations that have been described with cystic fibrosis. The more severe mutations lead to lifelong lung problems and a shortened lifespan, but there are definitely mild variants. Some of these present with congenital bilateral absence of the vas deferens, so those patients often come to our attention when they present with infertility and are found to have azoospermia. The other disease that we've been screening for a long time are the hemoglobinopathies, which is a number of different diseases. The most common of which is sickle cell disease. Sickle cell has a very high carrier frequency in the African population of approximately 1 in 13. This is thought to be due to heterozygote advantage of having the sickle cell gene in a heterozygote form is protective against malaria, which is likely why it persisted in such a high frequency in the population. However, if you have 2 mutations that result in sickle cell disease, that causes painful sickling crises. Other diseases that are in the hemoglobinopathy category include beta thalassemia as well as alpha thalassemia. Beta thalassemia is most common in individuals of Mediterranean, Asian, Middle Eastern, Hispanic, and West Indian descent. Alpha thalassemia is more common in individuals of Southeast Asian, African, and Western Indian descent, as well as individuals with Mediterranean ancestry. Current recommendations are that screening for hemoglobinopathies should be performed in high-risk ethnic groups. So this includes African, Mediterranean, Middle Eastern, Southeast Asian, or Western Indian individuals. The best way to screen for hemoglobinopathies is with a hemoglobin electrophoresis, as well as a CPC, a complete blood count, looking at the MCV. There are DNA-based assessments that are available, but they are not as accurate as the hemoglobin electrophoresis test. So for a while, that's all we did. We screened everyone for, or offered screening for everyone for cystic fibrosis, and then screened for hemoglobinopathies based on ethnic group. Then along came spinal muscular atrophy. I was surprised to learn in researching this talk that ACOG did not recommend routine screening for SMA until 2017. ACMG, which is the American College of Medical Genetics, recommended screening several years earlier. So most in the REI world adopted routine screening for SMA for all patients. At our practice, that started in 2012. Spinal muscular atrophy is a pretty severe disease. It results in atrophy of spinal motor neurons. It is fairly common in the population with a carrier frequency of 1 in 40, and it's a pan-ethnic disease, so not more common in certain ethnic groups. And in its severe form, while there are some new treatments that are on the horizon, in its severe form, it leads to progressive neonatal decline due to muscular atrophy and usually death by 2 years of life, so a fairly severe disease. Yeah, next disease that we've been screening for fairly commonly is something called Fragile X syndrome. Fragile X is the most common inherited form of intellectual disability. It can cause autism, autism spectrum disorders, as well as intellectual disability and ADHD. The incidence of this in the population, this is an X-linked disease. It affects approximately 1 in 3,600 males and approximately 1 in 4,000 to 6,000 females from a variety of ethnic backgrounds. This is thought to be an underreported disease. So there are individuals who have this disease that most likely have not been identified yet. Fragile X, you should think of it as being transmitted in an X-linked fashion. However, the molecular genetics of the syndrome are actually complicated. The magnitude of risk relates to the number of CGG repeats in the Fragile X gene. So a lower number of repeats results in a normal phenotype. Then there's an intermediate phenotype. The genotypes that are of concern are the pre-mutation and then the full mutation. So the full mutation results in a classic Fragile X phenotype, or can result in that. A pre-mutation can expand in the next generation. So these CGG repeats expand, especially when they're in the maternal line, and can result in a child with Fragile X disease. Fragile X screening is recommended for anyone with a family history of unexplained ovarian insufficiency or an elevated FSH hormone before the age of 40 years. We typically do also screen individuals who have a low AMH, since those individuals, since AMH is also predictive of ovarian insufficiency. And anyone with a family history of unexplained autism spectrum disorders or intellectual disability should also be screened for Fragile X. Next disease that we'll talk about is something called Tay-Sachs. Tay-Sachs was initially described in Jewish populations with an incidence of 1 in 30 in Ashkenazi Jewish populations. The incidence in the general population is considerably lower, approximately 1 in 300. It was later found to be more common in individuals of French, Canadian, and Cajun descent as well, due to a founder effect in those populations. Tay-Sachs is a progressive neurodegenerative disorder, which results in progressive decline and usually death in the first few years of life. So again, a fairly severe disease. The most accurate way to screen for Tay-Sachs disease, there are DNA-based testing that's available, but the most accurate way is to look at the enzyme activity of hexaminase is the name of the enzyme. And that screening should be performed for individuals who are of Ashkenazi Jewish descent or for French Canadian or Cajun individuals. And this brings us to Jewish population screening in general. A number of clinically significant autosomal recessive disease conditions are more prevalent in individuals of Ashkenazi descent. I put a number in quotes there because ACOG recommendations on this have actually gotten a little bit vague. ACOG does recommend that all individuals of Ashkenazi Jewish descent be screened for cystic fibrosis and Tay-Sachs disease, which we've already talked about. They also recommend that all of those individuals also be screened for Canavan's disease as well as familial dysautonomia. And then there's a list of other diseases that they say you can screen everybody for, or you should at least at a minimum ask about a family history of any of those following diseases in that second bullet point there. The reality is that over 100 autosomal recessive diseases have been described as more common in individuals of Ashkenazi Jewish descent due to both founder effect and antigenic drift. There's a wide variety of Jewish panels that are now available. Some of those contain greater than 100 different recessive diseases, so a much longer list than what you're seeing here. So this brings us to what our paradigm should be in screening individuals as more and more recommendations are made and more options become available. What I have described to you so far is targeted or ethnic based screening. This does rely on the patient to know both her family history as well as her ethnicity or ancestry. There are definitely patients who know that information. There are also patients who definitely don't know that information. And finally, there's some patients who what they think they know is wrong. So we've probably all had a patient or a colleague or a friend do a 23andMe and discover that they're 20% Italian or whatever it is. Well, if they're 20% Italian, should you screen them for the thalassemias? Yes, you probably should. So that does impact what type of tests you would order. So what we're starting to see now is the emergence of pan-ethnic panels. Panels that are described as pan-ethnic typically encompass all of the diseases that I've previously covered with you. There's sometimes a couple other bonus diseases thrown in there that have a higher carrier frequency in the population. But what we're seeing more and more now is these expanded carrier screens, which is a much longer list of different recessive diseases. Many of these are very rare, but if both parents are affected, then they are something that can certainly impact their family. So the goal of genetic screening is to provide individuals with meaningful information that they can use to guide their pregnancy based on their personal values. ACOG does state that any of these approaches, targeted, pan-ethnic, or expanded carrier, are appropriate ways to offer screening in your practice, and that your practice should establish a standard approach that's consistently offered to each patient. However, if a patient requests a different approach, so if you routinely offer a pan-ethnic panel and they want to do a targeted panel, that you should offer that, as well as vice versa. If you routinely offer a targeted panel and the patient is interested in an expanded carrier screen, that should be offered. So to be defined as an expanded carrier screen, there's not really a standard approach to that. ACOG recommends that any disease that's offered on an expanded carrier have a carrier frequency of approximately 1 in 100, have a well-defined phenotype, and have a detrimental effect on quality of life, so causing cognitive or physical impairment, or requiring surgical or medical intervention, or have an onset that's very, very early in life. There's several genetic companies out there that now offer expanded carrier screens. They all have slightly different panels. So we very commonly use the SEMA4 expanded carrier screen, which has 283 different diseases. There's a council panel that has 175 different diseases. Natera has, I think, 302 different diseases. So they're all a little bit different in terms of what their panels encompass. It's not surprising that as we've cast a wider net here in screening for different genetic diseases, we are finding more and more carrier couples, especially in our infertility patients. So why do this testing? Well, the options available to the couple are several. They don't obviously have to do anything with the information that is learned. They can go with it and just understand that they may have a higher risk of having a child with a problem, or be reassured that their risk is reduced. They can get pregnant and screen the pregnancy depending upon the disease via amniocentesis, and then make the decision if they choose to terminate that pregnancy. Obviously, in some cases, this might inform a decision to not try to achieve pregnancy or to adopt. Using sperm or egg donation is an option if certain diseases are desired to be avoided. And then the final option, which we'll spend most of the rest of the talk talking about, is to do IVF with pre-implantation genetic testing. So a word about nomenclature here. So the nomenclature has changed over the last few years. What we now call PGT-M formerly was known as PGD. So PGT refers to pre-implantation genetic testing. The M in this case refers to a monogenic defect. So these are single gene diseases. So all of the diseases that we've talked about thus far are single gene diseases. So screening for those would involve performing PGT-M. So how do we do this? Well, this will require the IVF process, which most of you are probably familiar with. So IVF will involve taking gonadotropin injections for the female for between 8 and 14 days to stimulate the ovaries to produce multiple eggs. At the end of that 8 to 14-day stimulation phase, we would do an egg retrieval procedure. This is a transvaginal ultrasound-guided procedure that is done under anesthesia. We would combine those eggs that have been retrieved together with sperm in the lab and then have embryos. My 13-year-old son showed me how to embed a YouTube video, so hopefully this works. What you're seeing here is an embryo dividing in the lab under the microscope. So it's gone from the 1-cell stage to the 4-cell stage. And is now continuing to divide. This is a time-lapse video over a course of approximately 5 days for an embryo to develop. And at this point, it's developing into a blastocyst, which has 2 different cell lines. So what you saw in that video is the embryo developing from the 1-cell stage to a cleavage embryo. On day 3, embryos typically have approximately 6 to 8 cells. And then by day 5 to 7, they've reached what's called the blastocyst stage, which is greater than 100 different cells. This is a stage at which we would perform an embryo biopsy for PGT. So this is the structure of a blastocyst. A blastocyst is a 3-dimensional object. You're looking at a cross-section here. The outside in purple is the zona pellucida, so that's the shell around the embryo. The orange cells are trophoblast cells. Those make up the trophectoderm. Trophectoderm will ultimately develop into the placenta as well as the extraembryonic tissues like the amniotic sac. And then the blue cells are embryoblast cells, referred to as the inner cell mass. Those are the embryo, or the cells rather, that are going to develop into the embryo and then ultimately into the fetus and then the baby. The part that we're going to biopsy with PGT is the trophectoderm, so the trophoblast cells are going to be removed for the biopsy. So this is a video of how a biopsy is performed. So what you see on the left is the holding pipette, and then we have your embryo. So you can see the outer trophectoderm as well as that inner ball is the inner cell mass. The bright light in the middle of the screen is the laser. And that laser is going to be used to make a small hole in the zona pellucida. This technique is actually slightly different than what we do in the lab now, but it gives you an idea of how these biopsies are performed. So a small hole in the shell. And next, the biopsy pipette is going to come in. And some of those trophectoderm cells are going to be aspirated. We are typically removing between 5 and 10 cells from the trophectoderm. So that's what's going into the holding pipette now. And then that laser is going to be used to snip off the biopsy. So you'll see that laser go back and forth now to snip off that biopsy specimen. And then the embryo recoils a little bit after the biopsy is performed. So at this point, that biopsy specimen would get sent off to the PGT lab, and the embryo would get cryopreserved on site here at the IVF lab, either in Massachusetts or the IVF lab in New Hampshire. We get those results back approximately 2 weeks later. So we'd get this is an example of what the result would show. So it would indicate whether the embryo has the correct number of chromosomes, which if that has been ordered, and we'll talk about that in a minute, as well as whether or not the embryo is affected or a carrier embryo or an unaffected embryo. Once we have those results, then we would start a frozen embryo transfer procedure. That takes about 3 weeks to transfer the embryo at the appropriate point in the menstrual cycle. The bottom picture there is a picture of an embryo transfer, which is performed under ultrasound guidance. So the bright white line is the embryo transfer catheter going into the uterus, and the air bubbles at the top fundus part of the uterus is where the embryo is once it has been transferred. So PGT-M can be performed for autosomal recessive diseases as well as for X-linked disorders. So obviously, since we're screening individuals for autosomal recessive and X-linked disorders at the time when they present for infertility treatment, many couples are coming to our attention that way. Other times parents come to us because they've had an affected child. So if they've had a child with cystic fibrosis and they later learn that they are both carriers for that disease, they may seek IVF with PGT-M to reduce the chance of having another child that's affected with that disease. In that case, those couples don't typically have infertility. We can still do the IVF process for the purpose of doing the PGT-M for them. Many practitioners ask me about insurance coverage in those situations. Typically, if the couple has coverage for IVF treatment, which most couples do now, both in Massachusetts and in New Hampshire, then typically that treatment would be covered. That is considered an indication for performing the IVF. Other situations in which we perform PGT-M are HLA matching for a sibling who needs a bone marrow transplant. Siblings have approximately a 25% chance of being an HLA match for their sibling. There's a whole ethics discussion that goes along with those cases that I'm not really going to get into today, but we do see those cases from time to time. And then the final category here is autosomal dominant disorders. So an autosomal dominant disorder obviously means that the parent would be affected with that particular disease. Cases in which parents may seek PGT-M for these cases are Huntington's disease. I have a couple patients with Huntington's now in my practice. I also have a patient right now with neurofibromatosis who is choosing to use PGT-M to decrease their risk of having a child with that same disease that they have. And then the next category that we're seeing more and more commonly with autosomal dominant inheritance is cancer genes. So I'm going to use the example of the BRCA gene since that's familiar to most OBGYNs, but there's many cancer predisposing genes that have been identified and more are becoming identified. So screening for these types of things is becoming more and more common. BRCA mutations occur in approximately 1 in 400 individuals in the general population. They are more common in individuals of Ashkenazi Jewish descent, so 1 in 40 carrier frequency in that population. There are hundreds of different mutations in the BRCA genes that confer different levels of risk, and they are inherited in an autosomal dominant fashion, so 50-50 chance that your child would inherit a BRCA gene if you yourself are a carrier. So screening for these types of genetic diseases does sometimes influence decisions. And there's a variety of different decisions that patients make when they hear this information. This is results from a multi-center survey study asking patients who are being screened for BRCA what they intended to do with that result. A minority said that they would be in favor of not having children or in favor of adoption. And there were several individuals who indicated that they would pursue pre-implantation genetic testing if they learned that they were a carrier. So ACOG does state that I have an ethics statement about adult onset conditions. Their key point is that pre-implantation genetic diagnosis for adult onset conditions is ethically justifiable when the conditions are serious and when there are no known interventions for the conditions or the available interventions are inadequately effective or significantly burdensome. Obviously, there's some degree of interpretation there. This is obviously a very personal decision. If an individual has an adult onset condition, choosing to test their embryos, I think, is a very personal decision. The other thing to consider is that medicine is likely to change in the next 40 years. So a BRCA diagnosis today is manageable, but the management options are pretty invasive. So having a child that may have to have an early mastectomy and oophorectomy to avoid having a high risk of cancer is a lot to think about as a parent. But keep in mind that in 40 years, we may well have different treatment options available. It's hard to know. So this may well be the tip of the iceberg. As I said, as we are doing more and more carrier screening, we are finding more and more couples and performing more and more PGT. At this point in time, we really only screen for genes that have a high penetrance, so a gene where the genotype is highly predictive of the phenotype. But there as more and more genes become described, if someone has a gene that carries a 1% chance of the child developing type 1 diabetes, you probably wouldn't screen your embryos for that. But if you learned that it was a 10% risk or a 20% risk or a higher risk, at what point would you consider screening? It's hard to know. There are complications of PGT-M. We sometimes see allele dropout. That means that the diagnosis for one of the genes cannot be made. If the other parental allele is negative, then you can consider transferring that embryo, because in that case, that embryo should at worst be a carrier of that disease. If the alternate allele is positive, then you would presumably not transfer that embryo, since that embryo could be affected. Recombination events can encompass the region of interest, and in that case, it may not be possible to determine whether or not that embryo is affected. Similarly to allele dropout, if the other parental allele is negative, then you can consider transfer of that embryo. And sometimes we get poor sequencing of the region of interest. So this can happen related to issues with the lab, issues with the machines, reagents, contamination. In that case, we can typically rebiopsy, retest those embryos, although it would be an additional 2-week delay until we get those test results back. In that case, the embryo has usually already been frozen. We would need to thaw it, biopsy it, and then refreeze it. A quick word about donor gametes. So most egg and sperm banks these days now do perform expanded carrier screening. It used to be that sperm banks really only screened for cystic fibrosis and SMA, and if the individual was a carrier for either of those diseases, then they didn't qualify to be a sperm donor. That has changed with expanded carrier screening because most people screen positive when you perform an expanded carrier screen. There are donors and sperm banks that have screened positive for a given disease. In that case, screening for the recipient should be offered. If the patient declines screening, then genetic counseling should be performed so that they understand their risk of having a child with that disease. Right, so now we're going to switch gears a little bit and talk about PGT-A. So PGT-A stands for pre-implantation genetic testing for aneuploidy. This was formerly known as PGT-S, and that is an outdated term that used to stand for pre-implantation genetic screening. So we now call that PGT-A. The vast majority of IVF patients who come back to you from an IVF center who say they've had PGT will have had PGT screening for aneuploidy. So let's look at how aneuploidy happens. So you're all familiar with the process of meiosis, which is the process by which the parental gametes divide in half to make either eggs or sperm. Oocytes are arrested in prophase of meiosis 1. And then complete the rest of the meiosis process, division of the chromosomes at the end of fertilization. So meiosis is the process by which a diploid cell becomes a haploid gamete. Genetic diversity is introduced during the meiosis process via recombination. So the parental and parental chromosomes cross over to combine genetic material during the meiosis process. And there can be errors in meiosis that lead to non-disjunction, that lead to aneuploidy in either eggs or sperm. So on the left here, you have the normal process of meiosis. In the middle, we see non-disjunction occurring in meiosis 1, and on the far right, we see non-disjunction occurring in meiosis 2. In these cases, the gametes, the eggs of the sperm, will have an uneven number of chromosomes. So instead of having 2 chromosomes, as they're supposed to have here, there is an extra chromosome or a missing chromosome that can result in a monosomy or a trisomy. So these are the classic descriptive studies that you've probably seen before in other REI lectures that look at the impact of age on fertility. So if we look at naturally conceiving populations, fertility declines with age. On average, that process starts in the early 30s and starts significantly after 35. And corresponding to that, the risk of miscarriage goes up as women age. So that process also starts in the early 30s and starts significantly after 35. And the reason for this is that non-disjunction risk increases as women get older, so there's a higher risk of aneuploidy in the eggs. And when we test embryos, not surprisingly, we see a higher rate of aneuploidy as women get older. So when we perform PGT-A testing for individuals who are under the age of 30, approximately 30% of their embryos will have chromosome abnormalities. If we screen people who are over the age of 40, 65% of those embryos, so more than half of embryos, will have chromosome errors. And then over the age of 42, that number goes up to 80%, so quite a high risk. Now keep in mind that outcomes, if we were to transfer an aneuploid embryo, most of these embryos just don't implant at all. So it's an embryo we put back to the uterus and pregnancy just does not occur. But the other outcome you can get is a spontaneous abortion. So the most common cause for miscarriage is chromosome abnormalities. And then the third outcome that you can get is birth of a child with a chromosome abnormality such as Down syndrome or trisomy 18 or 13 or some of the other genetic syndromes that we see. So the most common chromosomal reason for spontaneous miscarriage is trisomy. Trisomy 16 is the most common cause for SAB. The other possible causes include polyploidy, Turner syndrome, 45XO karyotype is also a fairly common cause for miscarriage. And sex chromosome imbalances can also lead to miscarriage. So even more minor chromosome errors can definitely increase the risk of miscarriage. Aneuploidy is the predominant cause of pregnancy loss. So 70 to 80% of early pregnancy losses occurring between 4 and 7 weeks are due to aneuploidy. Approximately 50% of later losses in the 11-week time frame. And then even late second trimester losses, approximately 30% of those are related to chromosomal aneuploidies. Miscarriage is of particular concern, especially in our older patients with infertility, because if we do a treatment cycle that results in miscarriage, by the time we diagnose the miscarriage, they're usually approximately 7 weeks pregnant, and then we need to wait for that pregnancy to resolve, which will typically take a couple of months. And then there's usually one rest cycle where we update a uterine cavity evaluation before they proceed on to further IVF treatment. So it ends up being a 4 to 6 month time frame from doing a treatment cycle that results in miscarriage to doing your next treatment cycle, which is particularly relevant. It's hard for any patient to go through that, but it's particularly relevant from a medical perspective in our older patients, just because time is not so much on their side. So doing PGT-A is useful in reducing miscarriage risk at the time of IVF. It does decrease the whatever the age-related risk is to approximately 5%. So it doesn't eliminate that risk, but is definitely risk reducing. It's important to understand that pre-implantation genetic testing for aneuploidy is somewhat controversial as far as exactly which patients should receive PGT-A. The ASRM statement, committee opinion, states that the value has yet to be determined. Several studies have demonstrated higher live birth rates after aneuploidy testing and single embryo transfer, suggesting the potential for this testing to decrease the risk of multiple gestation, but they do note important limitations. Those limitations are just the value of the studies that have been done to date. There are some randomized controlled trials that have been performed looking at PGT-A. The critique of those studies is that they predominantly used patients with a good prognosis, so patients who had good quality blastocysts, and often younger patients. Some of the randomized studies also looked at fresh embryo transfers due to improvements in how we do IVF with freezing and vitrification. Most of our PGT-A tested embryos now are done as a frozen embryo transfer, and we have less data to say that that's beneficial. If we look just at the national data, overall, there doesn't seem to be an improvement in pregnancy or live birth rate in women who are under the age of 37. There is improvement in live birth rate in women over the age of 37, but according to the national data, 21 cases need to be treated in order to achieve one additional live birth. So some centers apply PGT sort of across the board to every patient who comes in for it. We at Boston IVF, I think, take more of a data-driven approach. So this is a study that we did that was presented at ASRM. This is a retrospective study looking at over 18,000 births at our center and looking at the effect of PGT-A on live birth rate. So in our younger patients who are under the age of 38, if we look at live birth rate per retrieval, there's really not a difference in pregnancy, whether you do PGT-A or you do not do PGT-A. If we look at our live birth rate per transfer, we do see an improvement in live birth rate. And that makes sense because if we've done the PGT-A, we will have screened out embryos that have chromosome abnormalities, so we won't spend time transferring them. Keep in mind that even if we get to a retrieval, we don't always get to a transfer because some embryos will arrest and stop growing in culture. And so sometimes we don't have embryos to transfer, so those numbers are different. In our older populations, so women over the age of 38, we do see a difference in live birth rate, both per retrieval as well as per transfer when embryos are screened. However, there are some drawbacks to doing the PGT. Time to pregnancy is longer, and that's true in our older populations as well as in our younger populations, and this is significant. So the IVF process without PGT is often a 1-month process from starting IVF medications to getting to hopefully a positive pregnancy test. IVF with PGT is more like a 3-month process from starting medications to getting to hopefully a positive pregnancy test because we have to biopsy and freeze the embryos in the middle of that. Sometimes we don't have a normal embryo with the first round, in which case we can do another egg retrieval with the goal of getting more eggs to work with and hopefully getting a normal embryo. So overall, the benefits of PGT-A, it definitely does increase live birth rate per embryo transfer. It does not necessarily increase live birth rate per egg retrieval, especially in our younger patients. It does decrease miscarriage risk, which is significant, and there's definitely value in that. And then it also increases the confidence of a single embryo transfer. So pretty routinely for women under the age of 37 these days, we transfer 1 embryo. For women who are older, we would typically transfer multiple embryos back if PGT has not been performed because we know that a majority of those embryos are expected to have random chromosome errors. So doing the PGT-A really improves our accuracy in picking an embryo that's likely to make a successful pregnancy, really increases our confidence in single embryo transfer and reduces the risk of multiple birth. The downsides to PGT-A, time to pregnancy takes longer, as I've shown you. PGT-A is typically not covered by insurance, so even health insurances that cover the IVF portion typically won't pay for PGT-A at all, so that is usually an out-of-pocket cost, varies between $3,000 and $5,000 to do that level of screening. And then the third downside is that there is a risk of an inaccurate test result. As with any test, there's a small chance that we call a normal embryo abnormal or vice versa. Adding further complexity to PGT-A testing is the fact that we have discovered over the last few years that many human embryos are actually mosaic embryos. So we learned in high school biology that all of our cells contain the exact same amount of DNA. So if we test an embryo, we would expect it to either be completely euploid, have all normal cells, or completely aneuploid, all contain a specific genetic abnormality. What we find is that there can be errors in mitosis. So most chromosome errors, aneuploidy, results from meiosis. But mitosis, that rapidly dividing early embryo, there can be errors there that then lead to some cells within the embryo containing a normal number of chromosomes and others containing an abnormality. It depends on where we biopsy the embryo as far as whether we're going to detect this or not. So we don't always pick up mosaicism, but sometimes in our biopsy, we do see a mosaic embryo. Embryos that are mosaic, interestingly, do sometimes result in live birth. So embryos that are defined as mosaic are definitely less likely to implant and more likely to result in miscarriage, which makes sense because there's some degree of aneuploidy that's been identified. However, over 100 live births and counting have been reported after transfer of mosaic embryos. So some embryos appear to self-correct, where the normal cell line continues and that abnormal cell line presumably either dies off or sometimes becomes confined to the placenta. So there have been cases of confined placental mosaicism where those abnormal cells just preferentially seem to be located in the placenta and actually are not present in that inner cell mass, which ultimately is what develops into the embryo and then into the person. Embryos, or individuals rather, with true embryo mosaicism have been identified after transfer of a mosaic embryo. Those individuals don't always appear to have abnormalities, although it's really hard to know since we haven't adequately studied that yet. And sometimes mosaic embryos can lead to something called uniparental disomy. That's when you inherit two pieces of DNA, either from mom or from dad. Because of differences in genomic imprinting and methylation, that actually can lead to specific diseases. And then finally, some cases of embryo mosaicism are showing up as being mosaic, but are really just representing limitations of the test. So our tests are not perfect. Sometimes the DNA is not amplifying as well as we'd like it to, or we're not detecting DNA that's there. So we're calling an embryo mosaic when it may not be. We will transfer mosaic embryos at Boston IVF if we've exhausted all other options. So the preference obviously would be to transfer euploid embryos. However, we do have a protocol for transferring mosaics. It does require genetic counseling as well as a specialized consent form if a couple wishes to do that. Situations in which that comes up, if we have a 43-year-old who's done 6 cycles of IVF and finally has one embryo that's mosaic, and that's her only embryo, that's a case when we would potentially consider transferring that embryo. And then our final topic for PGT is PGT-SR. PGT-SR stands for pre-implantation genetic testing for structural rearrangement of chromosomes. So this is a screening for individuals who may carry a balanced translocation or Robertsonian translocation or chromosome inversions or ring chromosomes. These come to our attention usually in couples with recurrent pregnancy loss. So 3 to 8% of couples with recurrent pregnancy loss will be found to have a chromosome rearrangement that is detected by a parental karyotype. Incidence is approximately 1 in 500 individuals. Balanced translocations can result in miscarriage or of live birth of an infant with structural or developmental problems. And then Robertsonian translocations are very similar. Robertsonian translocations affect acrocentric chromosomes. So that's a chromosome where the centromere is located very close to one end of the chromosome. The short end of the chromosome often gets lost, and the two long arms often get fused together. Acrocentric chromosomes involve chromosomes 13, 14, 15, 21, and 22. A translocation involving chromosomes 13 and 14 is the most common in the population. That one's pretty benign. It doesn't tend to cause major problems. The situations in which we see issues are translocations involving chromosomes 13 and 21. Those can lead to trisomy 21, which obviously results in Down syndrome, or trisomy 13, which typically results in late pregnancy loss or early neonatal death. So I hope that I've helped you to understand genetic carrier screening options that are available today and the various ways in which we can test embryos at the time of IVF. And I'd be happy to take any questions.
Thank you, Dr. Wright. That was a great informative presentation. We are now going to begin answering questions submitted during today's presentation. As a reminder, you can still submit questions through the questions pane in your attendee control panel. Dr. Wright, our first question is, if a patient is doing PGT-M, can they also do PGT-A?
Yes, and we would typically do both because if you're doing PGT-M, you will have already biopsied the embryo and already frozen the embryo. So we would typically order both of those screenings to be done on that same sample. The only situation which we wouldn't is if the patient just doesn't want to know. But typically, if we're doing PGT-M, then yes, we're doing PGT-A as well.
Okay, great. I have another question. What do you recommend for prenatal aneuploidy screening for patients who've had a negative PGT-A, NT with multiple markers of cfDNA and IPT?
We'd recommend routine obstetric care, so there really shouldn't be any change in how you screen pregnancies. Even if a patient has had PGT-A, a vast majority of the time the PGT-A is going to pick up an aneuploidy, like Down syndrome or other trisomies, but it's not 100% due in part to mosaicism or just accuracy of the test. So you should proceed with routine obstetric care for those patients. And we still strongly encourage that they undergo routine aneuploidy screening during the pregnancy, even though they've done the PGT-A, because PGT-A is risk reducing, not risk eliminating, and the prenatal screening is more accurate. There's more cells that are tested in that case.
Okay, our next question is, which is better, cfDNA or multiple marker screening?
I don't know the answer to that. I would defer to you. I assume cfDNA, but I don't know.
Okay, and then another question we had was, can you tell us more about the New Hampshire Center, if it's currently open yet?
Yes, so we are open in New Hampshire. We're very excited about this. So we will be bringing all IVF services to New Hampshire. So we're currently doing IUIs in the Bedford office, and we're going to start doing IVF procedures in a couple of weeks in April. So all egg retrievals, embryo transfers, and all the IVF lab stuff will be done right here in-house, as well as semen analyses.
Thank you, Dr. Wright. That was actually our last question. Thank you, everyone, for attending today's webinar on genetics and fertility. If you have any other questions, you can contact myself, Alyssa Cooper, at ecooper@bostonivf.com, or on my cell phone, it's 978-302-2958. Once you leave today's webinar, you will receive a survey on the presentation, and we would appreciate it if you would complete the survey and provide your feedback to help us with future educational webinars. You will also receive a follow-up email within 24 to 48 hours with a link to view a recording of today's webinar. On behalf of Boston IVF and Dr. Kristen Wright, thank you for joining us today, and have a great rest of your day. Thank you, everyone. Thank you, Dr. Wright.